Hi everyone, thanks for watching my videos. I'm back again, and this time around we're talking about irritable bowel syndrome, and I'll limit myself to the treatment because I have made a different presentation on irritable bowel syndrome, and then I've talked about the different types, the symptoms, how to make the diagnosis, and the differential diagnosis, even the cause, the prognosis. So if you haven't listened to that, I would advise that you listen to that first so that you can enjoy and grasp everything that I'll be talking about here. So today is about treatment of irritable bowel syndrome. Before saying anything, the first thing is to find out if this is the case that will be handled at my clinic or not. So refer if you discover there is unexplained weight loss, if you discover that this is associated with iron deficiency anemia, if there are nocturnal symptoms like nocturnal diarrhea, refer. If you know or you are suspicious that you are dealing with colorectal carcinoma, refer. If this is inflammatory bowel disease, you're not sure whether it's ulcerative colitis or Crohn's disease, or the laboratory investigation of lactoferrin and caprolactin is showing that, refer. If you are sure or suspicious that this is celiac sprue, you've done your antigliadin and antitransglutaminase, refer. So refer, and if you've ruled out all this and you think you are not going to refer, then let's go. First thing first, there should be good doctor-patient relationship, and all doctors know ethically what is acceptable and what is not ethical. You understand what I meant by good doctor-patient relationship, in the sense that the doctor must not be weary of the complaint of the patient, because they'll be going back and forth, making phone calls and so on, and the patient should not be too anxious to get things resolved and say, oh, the doctor doesn't even know what he's doing, or she doesn't know what she's doing. Because this is not a case that will just come and go immediately. Now, if you listen to my first presentation, I've listed out the possible prognosis. You can go over that at the very last slide on that presentation. So check my channel for irritable bowel syndrome and go to the very last slide. Then you'll have your mind at rest. You will not just be blaming your doctor all the time. The doctor must not be weary, of the patient that is not comfortable, and the patient must not too be anxious to be changing doctor just like that, because if you go around 10 doctors, you might not get cure per se. Education and reassurance is necessary. We need to take the patient through to let them know what they're dealing with and how to go about it. Lifestyle modification is where we're going to start from, because I don't like prescribing medications unless I don't have any other way to solve the problem. But if I have any other way, non-pharmacological approach is the best option. For me, I want to do that. But then dietary modification, we're going to go into details, though I'm not a dietitian. Dietitian could help. And of course, we can use pharmacology medications. So part of education will be we educate our patients on balanced diet, toilet rules. Someone is laughing somewhere. Are you going to teach me when to go to washroom or giant or toilet, as the case might be, depending on where you are? No. When it comes to constipation, we'll go into that. Decrease alcohol. Because you're complaining about bloating, about flatulence, and belching, right? Now, listen to this. Study the triggers. In fact, I should have started with that. When you study what triggers the constipation or diarrhea in you or the means, then we are halfway out of the problem. Then healthcare workers should be highly suspicious of abuse. So rule out abuse. And they have to decrease caffeine, sorbitol, and fructose. As much as it lies within your power, because you have the willpower to do what will make you comfortable, right? If that is the case, if you are having bloating, abdominal pain, and you are diagnosed with irritable bowel syndrome, either with predominant constipation or predominant diarrhea, then exclude gas-producing foods. I know this could be difficult because you are used to this, you are enjoying your life with this. Okay, let me quickly run over this list, then you can pause and go over them yourself. Beans, onions, celery, carrots, raisins, bananas, apricots, prunes, wheat jam, bagels, pretzels, alcohol, caffeine, lactose intolerance, avoid lactose. Take lactose-free diet. Be sure that the patient is not reacting to other milk products. Also watch polyols like sorbitol, mannitol, maltitol, and xylitol. You find that in apples, pears, apricots, cherries, nectarines, peaches, plums, watermelon, mushrooms, cauliflower, chewing gum, and confectionery, particularly if you are having diarrhea predominant irritable bowel syndrome. Avoid gluten. Add fiber if you're having constipation. For example, you can add psyllium or aspergillus. And if you have food allergy and you've been tested, stop it. Or if you study the trigger and it's a particular food, stop it. Increase physical activity, particularly if you are dealing with constipation predominant irritable bowel syndrome. Okay, that's what we call low FODMAPS. That is low fermentable, low oligosaccharide like fructose, galacto-oligosaccharides like wheat, barley, rye, onion, garlic, shallot, beetroot, pears, fennel, chicory, pistachio, cashews, legumes, lentils, and chickpeas. Also disaccharides like lactose found in milk, custard, ice cream, and yogurt. Monosaccharides like free fructose in apples, pears, mangoes, cherries, watermelon, asparagus, sugar snap, pears, honey, high fructose corn syrup. So you can pause, go over this list. As someone is asking, oh my gosh, how can I forgo all this? I'm not saying you should forgo all. First of all, know the trigger. Then take these ones in low quantity. Pharmacotherapy. You've done all. You've taken the history, you've done the exercise, you've adjusted your diet, you've done all. You're not winning, then we will start medications. So if we are dealing with constipation, I will start from something simple. No, that's what we call gastrocolic reflex. That is, after you finish dining at the dining table, you might have the sensation of going to the washroom. This is very pronounced in children, right? If that is the case with you, why wait? Go to the washroom, go to the toilet, go to the gym immediately. That will prevent constipation a lot without spending a dime. Okay, then if that's not the case and you are not using that, you can use cyanide, asparagus, senocort, polyethylene glycol, lubiprostone, linaclotide, plecanatide, prucalopride, 1 milligram per oral once daily. In women that are less than 65 years old, tegaserol can be tried, and tegaserol is also good for mixed type of irritable bowel syndrome, that is people with constipation alternating with diarrhea. Osmotic laxatives like PEG, lactulose, milk of magnesia could also be used if it is constipation. But note this, polyethylene glycol, that is PEG, will have bloating and abdominal discomfort as adverse effects. So we should use PEG less in irritable bowel syndrome if we have other items around that could be used. Also, lubiprostone is useful in women with persistent constipation despite the use of polyethylene glycol. In other words, if you use polyethylene glycol in a woman with constipation and is failing, do you know why I'm paying attention on women and constipation more than females? I have said in my first production on irritable bowel syndrome that women will likely have constipation more than men if they both have irritable bowel syndrome. That's why I'm paying more attention on females and constipation here right now. So, guanylate cyclase agonists like linaclotide and plecanatide could be used in persistent constipation as well. And sodium hydrogen exchanger, sodium hydrogen exchanger 3 inhibitor like tenapanol could also be used. I have never used either linaclotide or tenapanol, no. But just passing the details of what is available currently in the field of medicine. They could all be used for constipation, and particularly attention is on women because they come down with constipation more than the female counterparts. If it is diarrhea, you can use octreotide, particularly if that is not the place to start from anyway. You don't start handling diarrhea with octreotide. Loperamide is okay to start with. There is a separate presentation on octreotide. You can check my channel for that. So if the diarrhea has become recalcitrant, for a long period of time, and you want to use octreotide, 50 micrograms subcutaneously once daily is fine. You can use loperamide. Bile acid sequestrants like cholestyramine, cholestyramine, or cholecylamine could also be used. Alloxadolin and 5-hydroxytryptamine 3 receptor antagonists like allocetrone, hydrochloride, lotrones could be used. For pain and bloating, you could say I'm taking each problem one by one, right? For pain and bloating, you can use alzinamide at the dosage of 0.125 to 0.25 milligram sublingually. You can do that 3 times or 4 times daily. Dicyclomine, 20 milligram per oral 4 times daily. Mebeverine, pinaverine, or even using all these first medication, that is alzinamide, dicyclomine, mebeverine, pinaverine. Even some centers won't even use them when it's about pain. They will go straight to antidepressants. Antidepressant like tricyclic antidepressant, that is amitriptyline or nortriptyline. Amitriptyline is okay for not many people, but for the elderly I won't use it. I would rather choose nortriptyline for elderly people because it could tolerate nortriptyline better. But if I have my way out, I don't even want to use any of the tricyclic antidepressants. Do you know why? Because I will run away from their side effects. No, they have anticholinergic side effects, dry mouth, constipation. They have urinary retention, blood vision, and more importantly, the effect on cardiovascular system, arrhythmia, tachycardia. You understand what I'm saying? But to many people handling irritable bowel syndrome and dealing with the pain, they go straight to amitriptyline or nortriptyline. But in some parts of the world, that will be the last option. So they will try eosin, buscopan, diacylglycerin, mebeverine, pinaverine. The argument against eosinamide is that the pain and these antispasmodics will not solve the problem because the problem causing the pain is not spastic or it's not spasticity in the gastrointestinal tract. That is the argument. But if the patients are doing well, I'm fine. So some will start with tricyclic antidepressants, but I will take that as a last option when it comes to pain and irritable bowel syndrome. And you can use rifaximin. Some will use probiotics, but that is not routinely used. I've never used it. Some will use rifaximin 550 milligram TID to deal with overgrowth bacteria or whatever in the GI. Okay, you've done all, and you're not winning. Patient is anxious. What's going on? This problem is still there. You've given me all these medications. I'm not getting out. You've done education. You've tried trigger. You've done everything. Okay, refractory. Go for antidepressants. That's why I said a few minutes ago that I will reserve antidepressants to the end as the last resort when I've tried the rest and I'm not winning. Okay, so antidepressant, anxiolytics. Even if this person has not been diagnosed with anxiety before, but the fact that this problem is in his or her life and is not getting out quickly could lead to anxiety. Ketotifen is a mast cell stabilizer. Remember, in my first presentation on irritable bowel syndrome, I've stated that mast cell release could lead to pain. Fecal microbiota transplantation via colonoscopy could be done in some centers. I'm not exposed to that. And trying all this is likely that the patient will get out of the problem. And another thing that I need to leave is refer appropriately. Refer to appropriate centers. If you think this is a psychiatry case, refer to psychiatrists. If you think you're still dealing with functional problem with gastrointestinal tract, refer to gastroenterologist. And with that, I've come to the end of this presentation. Kindly go over the first presentation on irritable bowel syndrome and match it with this one, and you get the real picture and the complete picture. My prayer is that everyone suffering will find the right way out. Please remember to leave comments and subscribe to my channel. Forward it to your friends. Contact your doctor who will be able to help you better. Thanks. I appreciate it.